Hello. Thank you all for joining us today for our webinar on hospital-acquired infections, presented by Dr. Michael Mercy, Chief Medical Officer here at Prediction Software. During the session, we've set some time aside at the end of the session for your questions. So as your questions arise during the presentation, please use the question pane that's located in the GoToWebinar control pane on your screen. So let's go ahead and get started, and I will hand the microphone over to Dr. Michael Mercy. Mike?
Hi, Jennifer. Can you hear me?
Yes, we can. Thank you.
Outstanding. Great. So in this land of technology, I always want to make sure that everything's working and I don't get going before and nobody can hear me. So welcome, everyone. I am really excited to talk to you today about hospital-acquired infections. It's an area that I think we're all going to become keenly interested in if you're not already, but with respect to some of the exciting things we're going to talk about today. So just a little bit about myself. I'm a practicing emergency physician and work in a number of emergency rooms. I went to medical school back east in Baltimore at Johns Hopkins. After that, I became very interested in performance improvement. Did some training with Brent James at IHC, did some consulting work, and then became involved with Predixion at about the same time I was earning my MBA. So I've been excited about predictive analytics, and in particular Prediction software, and its implications for healthcare, and the fact that I think that it can really help be transformative in how we do performance improvement, increase the quality of care we deliver to our patients, as well as save money. So kind of get all things covered at once. All right. Well, let's set up the agenda so you guys understand what we're going to be talking about today. First thing is, of course, a little bit of background on hospital-acquired infections so you kind of understand where I'm coming from. We all are going to be talking the same language by the time this is done. Going to introduce you a little bit to predictive analytics and the concepts behind predictive analytics and explain why I think that they are so germane to healthcare. And then we're going to look at Prediction's healthcare solutions specifically and what we do in the healthcare space, which I think you'll find very interesting and hopefully innovative. And then lastly, we'll have a little bit of time for questions and answers. So I hope you enjoy the talk. So let's talk a little bit about hospital-acquired infections. You know, it is one of the paradoxes, I think, of our healthcare system that when you go to the hospital, it's actually one of those places that is incredibly dangerous, and a trip to the hospital can actually kill you. As we look at hospital-acquired infections, many of you may know that we have about 2 million of those a year. So you walk into the hospital unassuming, and 2 million of our citizens are going to have it or experience an infection they weren't expecting to get. It causes about 100,000 deaths a year. That is more than motor vehicle crashes, AIDS, or breast cancer combined. And about 9.4% of all inpatient hospital costs are related to hospital-acquired infections. That is about 2/3 of the Medicare and Medicaid population have HAIs, so very big problem. Hospitals have known about this for some time, and you know, we have been trying to work around this and trying to figure out exactly what we can do to combat this, but we have not made an awful lot of progress at this time. So what exactly are hospital-acquired infections? So I'm going to pre-warn you that I'm a physician, and so we always think it's great during these kind of talks to show pictures of actual medical conditions. So I will apologize before I show these pictures. Some of them are actual patients and actual clinical conditions. And I try to keep in mind that folks might not have quite the same medical background, but I ask you to bear with me. So there are a variety of common hospital-acquired infections. I'm going to show you sort of the top 3, if you will. And you can kind of think of these, as I like to think of them, as weapons of mass destruction. There are things in our hospital that are as dangerous as anything we have out there. What you're looking at here is a catheter inserted into the skin of a patient, and you can appreciate that as that catheter is inserted in the skin, it's looking a little puffy, a little red. And then here's another absolute weapon in the hands of any nurse, a Foley catheter, this urinary catheter. These two instruments are associated with very significant infection. And so what you see on the right-hand side of the screen, the top cartoon represents what you'd see in the bloodstream. So this is a catheter-acquired bloodstream infection, and you see gram-negative rods floating around in the bloodstream. And below, the fuzzy little yellow balls are actually Staphylococcus aureus, MRSA, which we'll talk about in a little bit, and that is more commonly associated with indwelling central line type catheters. But both of these type of medical instruments cause a significant amount of infection and sepsis and complications in healthcare. So moving on to the next class. You've got here sitting an unassuming ventilator, the kind you might be able to find in any random ICU. But this too can be an engine of mass destruction. Once you put a breathing tube into a patient, you've built a conduit to the lung tissue, and in patients who are on a ventilator, we know they're already very sick, and you've built this conduit, and bacteria can breathe into the lungs and set up something that looks like this. You see on the top X-ray, panel, a chest X-ray, and a completely opacified left lung, which to me as a clinician shows that this person's got a large pneumonia. And below, if you were to do a bronchial scrape, you would see what I see here, which are some epithelial cells from the lung, and then those little black dots are all bacteria, and in this case they look like diplococci to me, so they're probably pneumococcus. Not that that necessarily means anything. I'm just trying to qualify to you that I am, in fact, a real doctor. So that is ventilator-acquired pneumonia, another big killer in our hospitals and something that's relatively common. The last, I see some folks have questions. No, this is probably the most dangerous weapon in the hospital, and it's going to certainly make you think hard about the surfaces you touch and touching people's hands when you shake, when you greet them, and shaking folks' hands. Anytime, all of us know we have young kids, you try to stay away from them as much as possible during cold and flu season because they just seem to carry those germs everywhere on their body. But in healthcare, of course, we carry around some of the most dangerous bugs in the world, and they live on our hands, and we can very easily introduce them into the healthcare setting. So MRSA in particular is a problem. MRSA used to stand for methicillin-resistant Staph aureus, but we don't make methicillin anymore, so now it's called multiple resistant Staph aureus, which means it's resistant to multiple antibiotics. And so again, you see these little fuzzy balls. This represents staph. It's an electron micrograph of that. And then what you're looking at is a very characteristic infection on a foot of staph. It tends to give you a very intense cellulitis and a very robust immunological response to which you'll typically generate an abscess, and that's sort of that hole you see in the middle of the foot is an abscess that's been drained and has some packing in it. So I promise that's the end of most of the gross spatial sites coming to get us. All right, so moving along. So the question is, we have hospital-acquired infections, and we've had them for a while. Why are they so dang important to us? Well, there's a number of reasons. The first is it costs us a ton of money to care for these things. It's something like $45 billion a year to annual health care costs to take care of just hospital-acquired infections. And these are things that, I think you'll understand at the end of this talk are eminently preventable. So that's money that could go directly to the bottom line if we could just stop from having these infections. We're also losing the antibiotic war. These bugs are smart, and as we throw more and more sophisticated and strong antibiotics at them, they are developing resistance. Survival is of the fittest, and these bacteria are able to find ways to resist even the strongest antibiotics, and we're getting to a point where we no longer can treat our way out of these bad infections. In the past, when I was training more years ago than I like to admit, we still had the upper hand on the bugs, and we could, if somebody had an overwhelming infection, it was likely we had an antibiotic that was stronger than the bacteria, and we could save the patients. But we're not at that point anymore, and Big Pharma, they may be investing money in these antibiotics, but it's so tough to get them to market that you know, we are quickly falling behind on that arms race. 2 million infections per year. To me, that is an incredible statistic. We talked about it earlier. And 100,000 deaths per year. I think what's interesting to me about this, if you break it down, 100,000 deaths a year is the equivalent of a Boeing 747 dropping out of the sky every single day of the year. So you can imagine the public hue and cry if this was occurring. Nobody would want to, no one would want to fly. They would demand investigations. There would be intense, incredible regulation of this industry to make it safe for everybody. In healthcare, always a different story. I don't know if it's the fact that when you head to the hospital, you are expected to potentially, you must be sick, and there's always a possibility that you could die. So again, 100,000 deaths per year. Think about that. These are folks who showed up at the hospital for routine admissions, procedures, etc., and ended up not making it out or dying shortly after they left the hospital. And as if that's not bad enough, CMS is going to start denying claims for taking care of people who develop HAIs. And in fact, they have. They've said, you know what, this is what we call a never event, as in it should have never happened. And because of that, they're saying, we're not going to pay for it. It's a complication. It's preventable. It shouldn't have happened. And we're going to begin to reverse some of these perverse incentives we have in healthcare where we pay you for managing complications of disease. Instead, we're going to say, bad on you. You get to eat that cost, and that you need to get your ship in order. So I think this is the context of why healthcare acquired infections or hospital-acquired infections are important. They're costly. We're losing the effective weapons we've had, and we're causing significant impact in the health of our population, and we're not going to get paid for them anymore. So what is this? We're talking about a transfer of risk from the payers, Medicare, Medicaid, and the private insurers, to the healthcare providers. And we're finally being asked to look at how we provide care, and we are now being held accountable for bad care that we deliver or care that isn't adequate. And so we are all going to get to play this game, and we're going to get to play it at our own risk. You know what's coming next with this. We're already seeing it with readmissions. As soon as we get through the initial push with CMS looking at how we take care of readmissions, the next thing down the line is going to be hospital-acquired infections. And they are going to be publishing rates. They are going to be penalizing hospitals that are below what is an acceptable rate. And so we have got to start getting ready to take care of this problem and be able to match it toe-to-toe and do something that's actually effective in taking care of this problem. So you can see here an example of several examples of HAI reporting. You know, this is just pulled off of the internet. It's out there. Folks are having to report this stuff. They have to show exactly where they're at. And if you look on the right-hand side, you'll see something from the Pennsylvania Department of Health looking at a number of hospitals in the Pennsylvania area. It looks like Northeast Pennsylvania. And you know, people are going to look at this and say, wow, you know, do I want to go to Geisinger, West Virginia? Do I want to go to Wilkes-Barre Hospital? Look at those rates of infection. And then sort of most alarming, you can't really see it on this screen, but the map of the United States is actually something from the government that's looking at how to get money back from places that have unacceptable rates of hospital-acquired infections in ambulatory surgery centers. So you know if they're rolling it out there that the hospitals are next. And you can see that it's basically, here's how much budget they are assigning to states. And so if you're black like California or Washington, They put a lot of money into looking at your facilities, auditing you, and asking you to pay back money that they paid you for managing complications. So if you live in Montana or South Dakota, Tennessee, West Virginia, you're going to be okay for a little bit, but everybody else looks like they're potentially at risk for these type of audits, and they're going to just continue to roll this forward. So we got to be ready. So what do we do? I'm not asking this as simply a rhetorical question. You know, genuinely, how do we stem the tide of this disease? There must be some kind of miracle cure that we can deploy. There must be something out there that folks are doing that is amazing, incredible, a magic bullet, and is going to save the day. So let's take a look at what is currently state-of-the-art treatment for hospital-acquired infections. So they always say, of course, an ounce of prevention is worth a pound of cure. And that's really where the state-of-the-art treatment is. So what do we have over on the cure side? You've got post-hoc treatments. You have medicines such as antibiotics. You have surgery where you can go in and cut out the infection or treat the infection that way. Or you can penalize people and try and get them to be motivated that way. And all these things, of course, are retrospective. You already have the infection or you've already sustained it, and now you're trying to fix the problem in a post-hoc way. Or you can try and prevent it. So you have the mighty ounce. And this, to me, is what's incredible. Here's state-of-the-art: hand washing, checklists, education, and disease surveillance. These are the things that we are armed with to treat hospital-acquired infections. And I'm not trying to say that these are not good things. Ever since I started really understanding where hospital-acquired infections come from, I make a point every time I walk into the exam room to, I guess this is probably bad, I shake everybody's hands, but then I wash my hands after that so that they know that as I go to examine the patient, I've just washed my hands, they're clean, and they don't have to worry about where my hands have been just before I walked into the room. Checklists, a good buddy of mine from Hopkins where I trained, Peter Pronovo, is the guy who, you know, sort of came up with the ICU checklists and trying to decrease hospital-acquired infections in the ICU, where, of course, they're kind of the most dangerous. And it's a simple and yet very effective tool. But it works well in the ICU because there's people there all the time. I think if we try to export that to the floor or to other places like nursing homes or rehab facilities where the care, there's just not as many providers and the care isn't as intensive, you know, something like a checklist can be limited in its effectiveness. Education, you know, education is great. I think we've all been in that circumstance where we've had to go to classes, we've had to understand things. Conceptually, we can get things, but when you try to get people to act on that education, sometimes you don't get the rollout that you think. I know that at Cedars-Sinai down in Southern California, they educated the doctors about the importance of washing their hands, making sure that their hands were always clean. They would track each physician around the hospital and see how often they wash their hands, and their rates of hand washing were abysmal, less than 50%. When they were able to actually embarrass the physicians by having everybody come to a big lunch, they advertised it, hey, we got free food, and you know doctors will always show up for free food. While they were there and everybody's in the room, they went around and took cultures of everybody's hands. And they basically grew out some gruesome organisms. And that was enough to finally embarrass the physicians into doing something substantial around hand washing, and they've seen their hand washing rates increase significantly. And then, you know, surveillance is another one of those things where, again, it's almost a post hoc sort of thing. In other words, you're looking at disease rates at your hospital in your state, and when you begin to see a spike in a certain disease state, you realize, oh my gosh, we got to go do something. You have to go in and drill down on that and try and figure out exactly what's going on. And of course, that is something that is post hoc, and you are essentially, well, it's sort of preventive. The proverbial horses are out of the barn at that point. So it appears that there is no magic bullet here. And of course, that would then lead everybody to say, well, maybe technology can help us. And I always, when I was a medical director, I always used to say, beware of the mythical IT fix. Because it always seemed that physicians would look to the IT departments and say, you know, you got to have something to help us out here. And I think technology does have a place, and obviously I'm CMO for a software company that sells predictive analytics into healthcare, so I really do believe that technology has something to offer. But I think, you know, like all things, it depends on how they're deployed, how they're used, and the understanding that we have of that technology. So I want to take a little bit of time here to sort of think about potential roles of predictive analytics in hospital-acquired infections, and then I'll give you a little primer on how predictive analytics work in case you're not up to snuff on that, because I know that when I was introduced to this concept, I was sort of like, predictive what? So my point being that we might not all quite understand everything that's involved in the technology and the potential of this technology to really do some wonderful things in many, many places in healthcare, not just inside the hospital, but population health. Looking at operations of hospitals. You'll begin to see, I hope, by the end of this talk, some real possibilities for predictive analytics. Specifically for hospital-acquired infections, are there individual factors that can influence the risk of developing hospital-acquired infections? And these are factors that are patient-specific. I think we all understand that if you wash your hands, if you're fastidious about cleanliness, if you closely surveil your infection rates, you can impact this. But are there things that are there factors that are patient-specific? Not everybody who goes into an ICU gets a hospital-acquired infection. And you can guarantee that they are exposed to the exact same carriers, if you will, of infection that everybody else is. So what is it about those patients, for example, that keeps them from getting a hospital-acquired infection? And therefore, on the other side, maybe there are factors that are weighing in on patients that make them predisposed to getting a healthcare-acquired infection. And we can determine what those are. So if we determine what those factors are, can we then predict in real time who is at the greatest risk, stratify the risk for the patients, and intervene early and come up with what I like to call a rational intervention? We'll see as we move forward. So just to talk a little bit about predictive analytics. Predictive analytics is a business intelligence tool that lets us look at reams and reams of data. And of course, we all know healthcare is incredibly good at generating data. And of course, we don't use that data very well. I know when I go to see a patient, you know, if there's somebody in the emergency department who's 60 years old, they probably have quite extensive medical record, a number of laboratory tests and diagnostics that have been done. Do I have the ability to lay my hands on that? Have we put systems in place around patients and around providers that allow them to access this information and be able to walk in for the patient encounter armed with everything we could be armed with? I think most of us would have to answer no. There are some hospitals out there that are very tech savvy and have great EHRs and are able to put a lot of data in front of the patients, and everybody's getting better. But on the whole, I think that we're probably still only scratching about 20% of the surface of what we could do if we were to truly leverage the data that we have. What predictive analytics allows you to do is take a look at all of this data we have. The human brain is capable of maybe holding about 3 to 4 variables at a time and testing them against each other to see if there's some kind of pattern, if there's some sort of knowledge that can be learned from that. When you start dealing with big data, you are dealing with exabytes of data. An exabyte, by the way, is about a 1 followed by 18 zeros. And just for a little aside, so you kind of understand just how big an exabyte is and how much data we're currently consuming, from the dawn of recorded history, really time as far as we're concerned, I guess, to 2003, we produced as a race about 5 exabytes of data. In 2010, we produced almost 1,000 exabytes of data alone. We're now at a pace to generate about 5 exabytes of data a day. That is as much as we made from the dawn of time to 2003 in a day. Not all of that obviously is healthcare related information, though sometimes when I'm filling out the paperwork I think that it is, but I digress. So we have a lot of data, and we now need a tool that can begin to cull through that data, parse that data, and begin to see patterns in the data and associations that our brains just simply can't do without a lot of aid. So we can begin to rely on our processors and the incredible work that our developers do in generating these algorithms and these models that allow us to see the data through an entirely different set of lenses than we would normally. And that, to me, is one of the things that is incredible about predictive analytics is, wow, I can begin to understand what's really going on, or at least have get a different view of my patients and the clinical processes that are going on that I maybe would have never thought of on my own. So with predictive analytics, after you've created a model, which we'll talk about in a little bit, the model will allow you to look for, examine all the data and create influencers for an outcome and show you associations. But most importantly, and what we're talking about here, you'll be able to generate a risk score. So what that means is that you can say, I'm interested in looking at this HAI condition, and I want to understand who's at greatest risk in my hospital for developing this type of condition. And once I understand who that individual is, I can begin to have proactive and rational interventions directed at that patient specifically. So this gets away from some of that cookie-cutter medicine that doctors are always talking about, how they don't want to practice cookie-cutter medicine. You give me some guidelines, you give me some type of nationally agreed-upon protocol, and I'm going to shoot it full of holes because, by God, my patients are sicker and they're different than the patients that were involved in that study, and it doesn't apply to me, and I can practice however the heck I want to. This is a way to sort of begin to show clinicians in particularly, hey, we can look at your patient's data. You can't, the argument that your patient's sicker or different goes away, and begin to identify all of the associations and influencers for your patient's disease condition. And then you can, as a clinician, look at those and say, wow, it kind of makes sense to maybe intervene here or here and make a difference. So you've kind of seen where I've been going with predictive analytics in healthcare. You've had a little primer on that. So let's sort of take a look at how it actually works. So in the past, it was the folks who did predictive analytics were statisticians, PhD level, lived in dark rooms, hardly spoke English, and they would be the folks who would be crunching the data, big machines, and allowing you to, they'd produce a model, they'd carefully roll out to you and let you use. And of course that model was the product, the output of these very big brains. Problem is, there are not an awful lot of these guys out there. So one of the things that I think is really neat about what prediction software does is they allow somebody who's not a big brain PhD to actually create the model. So what you see here are the red, yellow, and blue represent data, and the analyst with the computer. And what the analyst does is takes a look at the data and builds a model, helps the computer build a model that then they've tested and made sure is accurate. And out of that comes screens that show you what are the key influencers, what are the associations, how valid is the model. Physicians are always interested in accuracy. Everybody's interested in accuracy. But when you're treating patients, it seems like we want to make sure we're doing as close as we can ascertain to the correct thing. And predictive analytics, and in particular prediction software, as you'll see in a little bit, is very good at not only being accurate, but as you're building the model, you can see exactly how accurate your model is, and that's very important if you're going to roll it out into a clinical scenario. So how do we do predictive analytics at Prediction? You've got a clinical question today. We're talking about healthcare acquired infections, hospital-acquired infections. So what do? Interestingly enough, to me, you actually look backwards as a first step. You look at historical data, clinical variables, social factors, and you build a cohort. And the cohort is a number of patients for whom you know the outcome because it happened in the past. And you decide what clinical variables you would like to include in the model building. We always suggest that you include as many variables as you possibly can, but there may be some that you think are specific for your institution in particular. And we're building this model, by the way, on your data. So you take this cohort and you split it into two. And you have a training data set and a test data set. And what you do is you use the training data set to build the model. So the analyst is working away busily, building a model, having the computer generate this model, looking at the accuracy, testing it out on the test data set. And once you have that training data put into place, you will try it out on your other cohort and see whether or not you're getting good results. How accurate are you? How good is the model you built, and can you use it to predict, which is the most important thing. So then you move forward into today's world, and you say, all right, I've built an accurate model. It meets criteria for prediction, and we can now feel confident that when we plug in real-time data, we're going to get an output that shows us exactly what the risk is for this patient in particular. And so then you can begin to answer questions like, what's the probability of this patient developing a hospital-acquired infection? What's an intervention strategy that we could deploy? Is it cost-effective? What's the efficacy of the intervention? Does the intervention work well? You can begin to ask all these questions. And in the past, we didn't have that ability. Instead, what we'd have to do is what I like to call shotgunning the approach. In other words, if you're going to screen for colon cancer, everybody has to get screened for colon cancer. But we know that there are people who are at risk for colon cancer and probably deserve more frequent screening. Just as in the same breath, there are people who are at low risk for colon cancer and can probably go with a much lower rate of maintenance with respect to screening. But instead, we, at large expense and some discomfort for folks, end up screening everybody. Huge expense. This helps take that out of the loop where we can be rational about how we apply our resources going forward. And I think we can all agree that healthcare spending is out of control in any way. Any tool that we can use that helps us be a little bit more rational in the way that we deploy resources is something that we should be working towards. All right, so let's talk about how we can risk stratify healthcare acquired infections. So you are a physician or a nurse, and you're looking at your inpatient census because that happens to be your job, and you want to understand how many of these patients are at risk for developing hospital-acquired infection. So you have the models already built. You have prediction software loaded on your servers. You query the database. It churns away, and it brings out for you the same slice of your inpatient census, but now stratified into low, medium, and high-risk patients. And you know exactly who those patients are because you have the patient identifier. So it's not just you should have a percentage of patients who are at high risk. You actually know the risk score for the patient and the influencers for that patient for that risk score, which allows you to sit down and say, oh, I see, Mrs. Smith has a Foley catheter in. They've also put in a central line, and she's on a ventilator. I wonder if she might be at risk for developing a hospital-acquired infection. Now, obviously, you can see that yourself, but the ability of a software program to work on these sorts of things and come up with something that might be non-intuitive with respect to developing an HAI is not to be underestimated. In some of the hospitals we've looked at and other use cases, for example, around readmission, we've found that in a certain segment of the country, the leading indicator for readmissions happens to be the absence of an antidepressant for that patient. So it makes sense, but I don't know that a lot of people would have been saying, I'm going to prevent that congestive heart failure patient from coming back by putting them on an antidepressant. And yet, if you did that, statistically, you could intervene rationally on that patient and lower their risk for coming back into the hospital. I can't make it go away completely, but at least you're trying something that seems to make sense for that patient. Same case for hospital-acquired infections. It may very well be the case that there's something non-intuitive that you discover by looking for these crazy patterns in the data that only a tool like Predixion can do for you. As we talk about these risk scores a little bit, I want to digress just a little bit into just about how accurate your model is. And accuracy is measured in model building by something called a C statistic. And it basically gives you a score with a 1 being a perfect model. It always predicts exactly the condition that your patient's going to have. And 0, of course, being it is completely wrong. And 0.5 is essentially a coin flip. So in other words, are they going to get an infection or not? You toss the coin, you take a look, half the time you're right, half the time you're wrong. So when you talk about accuracy and model building, in predictive analytics, a C statistic of about 0.7 is considered good. And we consistently generate with our models about a 0.85 or greater with our models. So we have very, very accurate models. And of course, that allows you to feel confident in the therapy or intervention you are tailoring for your patient. So let's talk a little bit about Predixion and what we are and kind of what we offer. So obviously, we're a predictive analytics company. Our whole idea is we want to make predictive analytics accessible. We'd like to be able to bring, we always talk around the company, predictive analytics for the masses. And that's really what we'd like to get to. People could utilize this. There's so much data that we float in. Think of the power of being able to ask questions and get answers based on your own data. So, it's a vision. It's not there yet, but that's where we want to get to. But in the meantime, we can certainly make it accessible for your hospital. We want to make sure that we're basically providing this prospective information. We are augmenting retrospective analytics and reporting, and we're adding this perspective side to it, this real-time going forward, which in my mind has been missing in the healthcare field. When I did performance improvement, I would be frustrated by the fact that we had these incredibly long cycle times. I would look at, let's say, length of stay in the emergency department, and I would say, I think this is the reason we've got a long length of stay. And I would create an intervention, and then I would have to collect data for 3 months before I could show, statistically that I had a significant change. And it just change happens so slowly at that rate. And it's the same with any kind of process improvement you want to do. You're constantly in that collecting data and then trying to look backwards and figure out what you did. With predictive analytics, you get. I hope you're beginning to get the idea. You can begin to sit on top of real-time data and generate information about your patients, about your clinical processes that is actionable at that time while the person's still in the hospital. Incredibly powerful and I think transformative for healthcare. So what do we do in healthcare? We've started looking at a lot of the potentially preventable events. Many of you recognize that term out of 3M. We're looking at predictable readmissions, chronic condition management, comorbidity identification, looking at-risk populations, hospital-acquired conditions like hospital-acquired infections, length of stay. You can also use it for operations like determining how much blood you're going to need, how many nurses are you going to need, what staffing going to look like, what kind of supplies do you need for your laboratory, and then patient satisfaction scores as well. What are the influencers for patient satisfaction scores? I think we all debate about that. So here you see really the vision of Predixion software. This is our framework. We want to be able to go all the way from data acquisition to outcomes analysis and everything in between, creating the model, displaying the results, helping you with an intervention strategy, and looking at how well you did with that intervention strategy. And so you kind of look at the front end as risk scoring and all the things around the data, and then on the other side, when you're actually where the rubber meets the road with the patient, and you get to a point where you can actually have a recommendation engine. Nothing more than what sort of Netflix or Amazon does for you, right? They look at your purchase history, they look at other people's purchase histories, they find correlations, and they say, you know what, we think that based on the fact that it was successful for this patient, here's an intervention that may be successful for that patient. And again, I think this is, for predictive analytics, this really is the soup to nuts solution. So looking at how we do that, we think that there's sort of three areas that we can really help out in. The management views to better understand your patient population, help you manage on a macro level, and then you jump down into the more clinical levels where you have clinicians, individual patient outcomes, and they show a nurse here, but it could really be a line manager who's looking at their own piece of the pie and how can they optimize and make as efficient as possible their operations. As part of that, of course, I think you have to make these, the predictive analytic, the output, the end user interface, if you will, something that is easy to consume, easy for people to access. And what you're looking at here is a couple of things. Many people who are involved in managing hospitals, who are involved in managing people, looking at clinical processes, use Excel. And guess what? Predixion sits right on top of Excel. And with some special tools underneath, Power Pivot and SQL Server, which you don't necessarily need to know anything about, we're able to sort of take the power of Microsoft, do a lot of heavy lifting in the background, quickly, seamlessly, and then produce something to you that is in an Excel, very friendly Excel environment, and allows you to actually import data and export data from Excel when you want to look at things. So you're looking on the top at the ribbon, the Predixion ribbon that sits on top of Excel, and I won't spend a lot of time going into it, but it allows you to sort of do everything you need to do to get to the point of being able to have a model and do predicting, all the way from data preparation to generating the reports. And then below what you're looking at is our output, and the fact that we can tailor this output to any type of environment, but imagine the power of having this at your ready in an iPad or tablet or on your phone for the clinicians, for folks who work in the hospital, perhaps in case management. I was recently talking to a CIO, a CMIO, and telling them about this. And they said, well, we'd just be happy if they just look at their computers and forget about all this tablet stuff. But you know, we're thinking ahead, and we know this is the way of the future. I think the desktop computers are probably going away, and this is what folks are going to have. And so imagine if you could sit there, look at your patients, understand what their risk scores are, where you need to do work, and go do that work for that patient on a daily basis. Get an update as to where people's risk scores are, because we know that as you enter the hospital, these things can change, and as you update the model with new data, the risk score is going to change. And if you're interested in seeing this, you can contact us, and we can certainly set up a demo for you. So again, we're trying to really innovate on that ease of use. This has been the thing that for predictive analytics, it's, you know, that big brain in a back room generating the model. Nobody else knows how to do it, and they just give it to you, and then you get to just kind of decide what to do with it. Instead, what we want to do is make those models easier to create. We'd like to make them easier to share so that you can find out something interesting, highlight it, and email the link to your finding to the folks in your group who might be interested in this and get their feedback. I mean, it couldn't really be much more easy to share than that. And then lastly, easier to use. And what you're looking at in this pane is an actual list of current inpatients with a risk score, and you can see what the influencers are for that risk score, and you can then go in and decide to change something that is an influencer for them with respect to that risk score, and see whether or not, based on what the data says, it makes sense to do that intervention. Again, super powerful for what we do. So we are at about 45 minutes into this talk, and I have reached the end of the talk. I'm hoping that you, at the end of this, understand a little bit more about healthcare acquired infections, hospital acquired infections. I tend to use the word interchangeably because the nomenclature is kind of shifting. That you understand what we're dealing with hospital acquired infections, the magnitude of the problem, what are some of the typical healthcare acquired infections, what predictive analytics can potentially bring to the game as we try to manage this new game of risk that we're being pushed into, perhaps screaming and kicking, but it's coming. And then specifically, how a company like Predixion Software can create something that is easy to use, actionable, and can be disseminated across your institution easily, and give you real power to do something about some of these really tough clinical questions we have. So I want to thank you all for your attention and hanging in there while I go on about something that I happen to be really passionate about. And I will check with Jennifer and see if we have any questions.
Yes, Mike, a few questions came in during the session, and I'll just kind of start at the top and work my way through them. One of the questions came in is, how often are you having to train the models to ensure they keep predicting accurately?
That's a great question. And the answer to that is as often as you'd like to train them. The models are sort of self-learning, so as let's say that you have a medical condition that, of course, as you begin to intervene intelligently, the data begins to shift around those patients. So as that happens, the model is smart enough to actually learn that and sort of train itself, if you will. If you'd like to formally train the model, then all you have to do is contact Predixion. We will add whatever variables you'd like to look at and retrain that model, and can usually get it done within 24 hours. But it's not something that, like, every month you have to formally retrain it. The models are actually self-learning.
Okay, thank you for that. There was another question regarding how to segregate HAI from regular treatment and how to draw a borderline between original disease and HAI. It goes on to ask what variables or metrics would be considered in predicting that a patient would be getting an HAI, as it can happen despite all the precautions. So I guess the question boils down to, what are the variables or metrics that would feed into a predictive model, or some of them?
Right. So the first part of that question sounds like it was sort of, how do you determine, let's say somebody comes into the hospital with an infection that maybe you didn't know about, and then develops an infection while they're in the hospital, is one possibility. And it would seem to me that from a clinical basis, you could help differentiate that. Predictive analytics could potentially do it. But in terms of the variables, this is a kind of interesting part about predictive analytics, is that you want to load in the things that you think are important for your population. So we have some standard things, of course, that basic demographic information, certain disease conditions, if they're present in your database, your data warehouse, however you prepare your data. We would like to know, can you supply that data to us? Can we figure out how to make the plumbing to get to that? And that's one of the great things about what Predixion does, is we can get to the data in almost any format. And so if you have healthcare information that you think is pertinent to predicting on, we can get at it, whether that just be, if it's just demographic data, that's all you can really get at, great, we can predict on that, and we'll see if we can generate a model that is accurate enough to answer the questions you want to. But if you have the ability to tie in lab systems, pharmacy systems, medical records, diagnostic tests, anything that you think might be important in detecting whether or not somebody has a hospital-acquired infection, we will load that into the model and train that model and see what we come up with based on those variables. And like anything, because we're really looking at patterns and the associations of those patterns, really the more data you have sometimes, the better the results are going to be.
Okay, thank you. There's another question here about, can you pass the results back to your hospital information system?
I think what that question is asking is, so you can get it in Predixion. You're thinking, okay, I have a report from Predixion, great, now what do I do? Well, the idea with Predixion is you can actually tie this into your health information system, and this can become part of your IT, if you will. In other words, this platform sits in your IT environment and is in fact part of what your hospital gets. So you can literally have this at a nurse's station for a report. You can pull this up if you're the CEO or the COO or the CMO or the CNO and take a look at what's actually going on inside your hospital in real time.
All right, thank you. I'm looking through the questions here, and there are a number of some technical questions here. And unfortunately, I don't have the right technical resource to answer them online, but I will follow up on those technical questions and get you answers to all of those questions before the end of today.
Jennifer's very wise. She knows that us doctors, can't ever not say something. So I'd be making some sort of technical glitch that the development guys would be after me for.
No worries. All right. Well, I think that wraps it up for today. I want to thank you all for participating and joining us. We know how busy everybody is, and we do appreciate your time. And I just wanted to point you back to our website where you can sign up for a 30-day trial and get started. It's a simple download, and so you can start to explore within Predixion Insight. We'll also be having another webinar on Predixion on September 11th, and we invite you back to that. I will send you information on registering for that in the follow-up email from this session. But again, that's September 11th, and we'll be giving you a sneak preview of Predixion Insight 3.0 that will be released in the fall. So again, thank you. If any of you have unanswered questions, please know we will respond to you directly with those answers. So thank you again, and have a great day.
Yes, thanks, everybody.